Committee will come to order. We do not yet have a quorum, but we're going to be getting started. And do we now have quorum? All right. We do now have a quorum. We do not. All right, now we do. Representative Murphy moves the minutes from February 28th. Do we have any additions, corrections? Seeing none, all those in favor of adoption of the minutes, please say aye. Those opposed, no. Minutes are adopted. We have, first we're going to be doing an update on the February forecast related to CHIP and MinnesotaCare and VHP funding. We have Sean Welch, Director of Reports and Forecasts from the Minnesota Department of Human Services, and I think that's where we're going to start today. So if Mr. Welch and Ms. Snyder could come up. Welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Thank you, Mr. Chair. My name is Sean Welch. I'm Director of Reports and Forecast Division of the Department of Human Services.
Mr. Chair, my name is Susan Snyder. I'm Assistant Director of Reports and Forecasts at DHS.
Welcome to the committee. Please proceed.
Okay, thank you, Mr. Chair. Do we have the February forecast changes in a nutshell document? Was that, because that's what we'll be walking through.
Members, I think we have that in our packets. It's February 2018 forecast changes in a nutshell.
Yes. Okay.
And the numbers are in millions, so
Yes.
big nutshell. Yeah, there you go.
So, so starting at the very top, you can see the general fund total change in the current biennium is about $254 million, about 2.2% change. And in the out biennium is $162.4 million, which is a 1.2% change. You know, almost 90% of that overall change is the CHIP change. And without the CHIP change, we'd be looking at about a 0.2% change in each biennium. So in terms of the total general fund picture, there's not a lot going on in this forecast other than CHIP. But there are a few other things of note within the forecast changes. So we'll quickly walk through this and we'll stop at a couple of points and go into a little more detail. So,
Sure, so we'll start first with long-term care facilities. The change here is positive 18 million in this biennium and 22 million in the next biennium. And as Sean said, there aren't a lot of, we don't have a lot of major changes in our base forecast. We generally don't in the February forecast. We have 3 months of data that we add to the November forecast, and we compare that to how the forecast has done and make adjustments on that basis. So here the major change is the nursing facility recipient forecast is up between 1% and 2%. And this follows a substantial decrease we made in the recipient forecast in November. We brought the forecast down by 5% to 8%. And based on recent data, which has been close to forecast but a little bit above, we decided to adjust this upward just a bit, again, just 1% to 2% to offset that decrease we had before. So that's the storing facilities. Alternative care, there's a small adjustment in the recipient forecast downward. For long-term care waivers, there's almost no change in this biennium. We're up 2 million. And then a decrease of 38.7 million in the next biennium. And the biggest change here is due to DWRS, the disability waiver rate setting system. In that system, we made an inflationary adjustment in July 2017 to the framework rates. We recently received direction from CMS that they considered some of that increase to be duplicative. In response, we're removing 7% of that adjustment beginning July 2018. We are also planning on paying the full fiscal year 2018 7% increase at state cost, 100% state cost. So what you see here then is a net savings of 9.6 million in this biennium, which is partly reducing the rates by 7%, offset somewhat by the increased payments for state share in fiscal year 18. And then we see a bigger decrease in the next biennium. That's all the 7% rate decrease of $54.7 million. After that, we have an adjustment in the developmental disability waiver recipient forecast, an increase of 1% in the recipient forecast there based on recent data. And we have a decrease in the PCA recipient forecast of 1% based on recent data. And other than that, we have some other adjustments in average payments and recipient forecasts and programs that pretty much offset each other.
Okay, so for elderly and disabled basic care, part of this elderly waiver managed care is a part of our basic care forecast. And here there's just a small higher enrollment trend offset by slightly lower average payments. The net is a small change. In elderly basic, enrollment is about 1% lower and average payments are a little less than 1% lower, and they combine to create a $13 million reduction in the current biennium and about an $18 million reduction in the next biennium. For disabled basic, enrollment is practically unchanged, just a bit higher. Average payments are just a bit lower, and so they offset each other to create very small changes in both biennium. In the IMD program is up, and the reason is because we are starting to implement the 15-day rule, where if you are an MA eligible and you move into an IMD and you stay in that IMD for 15 or more days, the federal government will no longer participate in a match for that month of managed care. And so the way that we have implemented that is that the managed care plans send us monthly reports on who has moved into an IMD and in that month. And then we have to go on our side and manually change the system, the claims payment system, to change their eligibility from MA to IMD. And we're starting to work those reports now, and we've added some IMD capitation products to our list for people who continue on in IMDs beyond that first month. They stay in managed care now, but they're paid a managed care capitation product within the IM major program. And this activity is turning out to be sort of more costly than what we had expected, and that's essentially what you're seeing here with the $11 million increase in the current biennium and $33 million in the out biennium. The Medicare Part D clawback payments, this is just recognizing that we're actually being charged a lower per person charge rate in 2018 than what we had anticipated in November. And that then sets the base for lower charges in future years as well. So that results in about a $5 million reduction in the current biennium and $6 million reduction in the out biennium. Okay, so adults without children, there's essentially very small changes in adults without children, except for accounting for the repeal of the individual mandate. And so this is one of those areas where we'll go into a little bit more detail. You'll also see that this impact shows up in the families with children basic care category as well. And so the individual mandate has been repealed effective January 2019, and we know that when the individual mandate was implemented, we received a lot of additional enrollment due to the mandate. And so it's, it's likely then that there'll be some impact on enrollment now that the mandate is repealed beginning January of 19. When we first thought about how this was going to play out in our programs when it was implemented, we sort of thought that there's this pool of people out there who are uninsured, who have never shopped for insurance because they didn't feel like they needed insurance, and there was no penalty to not shopping for insurance, and so they're uninsured. And then when the mandate was implemented, now there was a penalty to being uninsured, and so a large group of that population came in and shopped for insurance through the exchange, and many of them, some thousands of them, found that they were Medicaid eligible. medical assistance in this state. And so they then went on to medical assistance, premium free, and now that they're sort of on our program, now that the individual mandate is repealed, we don't believe that these people are going to drop their premium-free Medicaid coverage just because the mandate was repealed. However, we think it is likely that in the future, people who would have shopped and become new additions to medical assistance, now that there's no penalty to not shopping and being uninsured, that they will not come into our program in as great in numbers as they would have if the mandate was not repealed. So we think this is going to basically lower the number of new ads into the future. And to put some numbers on that, we believe that over a 3-year period, it's going to accumulate to about a 1.5% enrollment reduction. And so beginning in January of 19, over 3 years, by the end of the first year, enrollment in MA, and we're talking about families with kids and adults without kids. So after a year, enrollment would be about 0.5% lower than it would have under the mandate. After 2 years, it'd be about 1% lower, and after 3 years, it'd be 1.5% lower, and then you would hit a steady state, and it would stay about that, that level. So in terms of numbers, by the end of our forecast horizon, we'll be about 2.5 years into that phase-in, and we project that we'll have about 3,000 fewer adults without children enrollees and about 9,000 fewer families with kid enrollees due to the repeal of the mandate. That enrollment reduction is what leads to these forecast changes. For adults without children, it's very small because the state share is very small in that program. For families with kids, it starts small because it doesn't come into play until January of 19, but then in the next biennium, it's about a $28.2 million forecast reduction. In terms of average cost for families with kids, our average cost in our 3 months of data that we updated is a little higher than expected, and so we have increased average cost for this group by about 0.5% on average, and it results in a $14 million increase in the current biennium and $27 million increase in the out biennium. Let me skip CHIP for now, and let's go to pharmacy rebates. We received more pharmacy rebates in our actual data, and the state share of those pharmacy rebates was higher than expected. And so that leads to about a 10% increase in our pharmacy rebates, and an increase in rebates, more revenue is a forecast savings. Okay, so then going back to CHIP. So Congress reauthorized CHIP for 10 years and appropriated funding for CHIP for 10 years. And so we have added CHIP back into the forecast. And while in the November forecast, it cost us $178 million to take CHIP out of the forecast, in this forecast, it's saving us $225 million to put it back in. So it's a little better deal to the state because the annual allotments that we were appropriated under the reauthorization is $122 million, which is more generous than what we had anticipated we would lose in the November forecast, which was $95 million. So we're getting about $27 million a year more in CHIP allotment than what we had anticipated in November, which is why we're saving more now, essentially, than what it cost us in November. So, okay. So we'll go on to the second page then. CD fund. CD placements are about 2 to 3% higher in this forecast. That's based on actual data that we're seeing coming in. And the average cost of CD placements are higher. And, you know, sort of our hunch on this is that we're seeing the impacts of the opioid use and meth use that's increasing CD placements. And we're also seeing that residential placements are rising faster than non-residential placements. And since residential placements are more expensive, that's what's in good part driving the average payment or the average cost increase. We don't have any data to sort of, you know, any diagnosis data to verify this. This is just our hunch. This is something we're going to try to look at between now and the November forecast.
For MFIP, the forecast is down due to average payments being about 1.5% lower. That's based on recent data. The Child Care Assistance Program is just adjusted in this biennium for recent data, no forecast change. The North Star Care for Children program is down due to lower average payments in the adoption assistance and kinship assistance programs, again, based on recent data. In general assistance, the forecast is down as well. Average payments about 1.5% lower, what we've seen in recent data. And housing support and Minnesota supplemental aid are both just adjusted for the recent data that we've seen downward. There's no forecast change.
Okay, so finally, we get to MinnesotaCare. And what you see here is just the state-only funded portion of MinnesotaCare, because the BHP side of MinnesotaCare continues to be all federally funded, and so there's no, while there might be changes in the forecast on that side, it doesn't impact this sheet because there's no state funding attached to those changes. So what you see here is the state-only funded enrollment is down. There's two groups that we fund state-only funded in MinnesotaCare. There's a group of elderly who have too much income to qualify for Medicaid, but they have too few work quarters to qualify for Medicare, for premium-free Medicare, and they're not eligible for tax credits because they're older than 65, and so they're kind of in no man's land, and so we cover them in MinnesotaCare. So it's the elderly group and then the DACAs. And the reason why you see a reduction here in the state-only enrollment forecast is we have a small trend increase in the elderly, but that's offset by phasing out the DACA population. Since DACA as a status is eliminated as of March 1st, we are assuming in the forecast that they will take no more renewals for DACA, no more 2-year renewals. And so those that have been renewed in the last 2 years will have some DACA status remaining on their 2-year renewal, and we assume that over 2 years the DACA status fades out, and so do the DACA eligibles on MinnesotaCare. And that phasing out of the DACA eligibles on MinnesotaCare is what provides the net reduction in enrollment. Average payments are up a little bit in the actual data, and that's reflected in a small $3 million and $5 million increase. Off of this sheet on the BHP side for MinnesotaCare, we have an enrollment reduction. And despite that enrollment reduction, we are still, all of the BHP enrollees are still fully funded out of the BHP Trust Fund. And instead of a $98 million bottom line, which we had at the end of fiscal year 2021 in the November forecast, that bottom line has shrunk to $86 million. And so since the BHP federal funding is not a match, we get their tax credits, not their cost sharing anymore, but we get their tax credits. When you take a person out of the forecast, you take away their cost, but you also take away their federal funding. And in this case, the federal funding that you take away is a little more than the cost that you take away over the 4 years, which is why you get a little bit of a drop from $98 million to $86 million in the bottom line of the trust fund. So I think that's all we have for the February forecast changes.
Representative Loeffler.
Thank you, Mr. Chair. And going back to the first page of the nutshell, might look like a small nut to some. For some of us, it's still big, the numbers. I see that the IMD program with managed care is not only $12 million in projected for the next biennium, but then it grows threefold to $33 million in the next biennium. And you said that you were working on an IMD capitation rate program and some other things. What are you doing to discourage the use of IMDs or the development of treatment facilities that would actually qualify for medical assistance reimbursement, since it's only the large facilities that don't qualify, as I understand it, those over 16 beds. What is DHS doing to control this through its development efforts or other policies to bring this down? I mean, a threefold increase is pretty high.
Mr. Welch.
Mr. Chair, Representative, I'm not sure I'm the best person to answer that question. I'm not sure. Yep.
Welcome to the committee.
Great. Thank you, Mr. Chair. Matt Burdick, Legislative Director for Healthcare and Behavioral Health at DHS. To your question, Representative Loeffler, we've got a number of initiatives ongoing to kind of deal with this. As the committee might remember, about 2 years ago now, we had to declare a pretty sizable portion of our residential treatment capacity in Minnesota as IMDs, and that sort of started this issue with the shift in our funding that you're seeing here today. We've got a waiver pending with the federal government to allow for certain programs as part of a demonstration project to actually recapture the federal funding that we had lost. And there's a number of kind of conditions on that. We'd be happy to come back and talk about that in more detail. We've also got a study that the legislature appropriated funding for last session as part of the larger substance use disorder reform package to look at programmatic models and funding models to get at that long-term sustainability that you were speaking to.
Thank you, Mr. Chair. I think that's a good direction to go, and I think it's in compliance with Olmsted and other pressures on us, not just budgetary pressures. So thank you.
Thanks.
Representative Liebling.
Thank you, Mr. Chair. I had a couple of questions. One goes back to the MFIP line on page 2, where you talked about the average payment being 1.5% lower. Is that because family sizes are lower, or why would the average payment under MFIP be lower? I mean, it's so low anyway.
Ms. Snyder.
Chair, Representative, I don't think we have the data analysis done to say why the average payment is lower in this forecast. I believe it is not due to family size. But there have been other ideas floated around. Maybe people have more income now, more child support, but we don't have any definitive answer right now why it's been lower.
Mr. Chair.
Representative Liebling.
Thank you. Well, I would appreciate if you could get some information to me on that. And I also wanted to just go back to the DACA, what was mentioned about that. And from what I understood from the news, a court just suspended that termination of DACA, and the Supreme Court, I think, refused to hear that. So right now, the law actually is that people can apply. So I understand that you had to do this at a certain point in time, but, you know, we may need some adjustment on that.
All right. Mr. Welch, I just had one question about the overall enrollment numbers due to the mandate change at the federal level. How does that work across our programs if we have the mandate that gets taken away? How does that translate into lower enrollment in each of those programs?
Mr. Chair, so are you referring to the adults without children and families with children categories?
Yes.
Yeah, so Mr. Chair, so there's, you know, in our programs, each month we have a certain number of eligibles in, you know, say, families with children, parents and kids. And some of those enrollees in a given month were on the month before, but many of them are new. And so we have churn that happens every month. We have thousands of people who drop off every month and thousands of people who apply and become eligible every month. And so while the enrollment may seem pretty, you know, fairly stable from month to month, there's a lot of turnover within the program over time. And what we're sort of assuming in the forecast is that since there's no penalty to being uninsured anymore, beginning in January, that people who would have come in and applied for our programs because of the mandate, will choose not to do so anymore. And so when you get that churn of dropping some and adding some every month, the adds every month will be lower than what they would have been under the mandate. And so you're dropping similar numbers of people for, income or noncompliance or whatever they're dropping for, but you're not adding as many people as you would have under the mandate, because people will just choose to be without insurance. They'll choose not to shop for insurance since there's no penalty.
And for folks who are, let's say you're on Medicaid and you become disenrolled through the churn process, you are, I would assume there's no changes in the immediate eligibility should they present at hospital or other facility to become enrolled again and immediately receive care without premium deductible or copay. Is that correct?
Yeah, the forecast doesn't really track, people like that. It tracks sort of the aggregate. And so to the extent that, that people are dropping and then showing up again in the future in a hospital setting or in some setting, we're sort of implicitly capturing that within the forecast in the base. And this change is just saying that, that because of that sort of process doesn't really have much, I don't think, to do with whether there's a mandate in effect or not. It's more the choice of people who are responding to, a penalty or not responding to a penalty. I think that's where sort of the fewer ads come from.
It would just seem intuitively that if you didn't have bills, the mandate wouldn't be as important to you as if you did have bills, and so that you'd see less churn on the public side, and also there would be no penalty if you were disenrolled, as opposed to if you were paying for an individual policy that might have APTC associated with it. Other questions? All right, seeing none. Thanks for the update.
Thank you, Mr. Chair.
Anna? All right, next we'll have MMB, Ms. Mingy. Welcome to the committee. Welcome back.
Thank you, Mr. Chair.
Please introduce yourself for the record and proceed.
I'm Anna Mingy with Minnesota Management and Budget. I'm an executive budget officer there, and I'm working on getting a PowerPoint up for you. While we get the PowerPoint ready, I just wanted to kind of tell you about the two documents that you should have in your packets. First should be a set of slides, which will be the presentation that I walked through today. But I hope you also have a copy of the Healthcare Access Fund summary and statement. It's not something I'm going to walk through line by line, but I just want members to know it's available for them. I'm happy to take any questions about this document now or in the future. This is one of my favorite things to talk about. So.
Makes two of us.
Oh, and I have my slides here too. I'm sorry, there's one. Okay, sure. So today my presentation is going to cover sort of the main sources and uses into the Healthcare Access Fund. The fund was established in 1992 to fund activities that promote access to health care, to promote the quality, have better quality in healthcare, and to contain healthcare cost growth. But over the last 25 years, the healthcare landscape has changed a lot, so I want to sort of give everyone an overview of where we are with the fund today. I'm also going to do a quick review of forecast changes that impact the fund balance in the February forecast that was just released yesterday. And then I'll have a quick discussion on the outlook of the fund because, as many people here are aware, there's some big changes on the horizon. So this chart shows revenues into the Healthcare Access Fund in the current biennium and the next. The largest source, the dark blue bar on the bottom, is the 2% provider tax, which is a tax on providers, hospitals, ambulatory surgical centers, and wholesale drug distributors. In the current biennium, the tax makes up about 80% of revenues into the fund, but the tax is scheduled to sunset on December 31st, 2019, which is halfway into fiscal year 2020. So that's why we show a much smaller revenue forecast for the provider tax in the next biennium. It's because it's only a portion of one fiscal year. The next largest revenue into the fund is a 1% tax on HMO premiums, and that brings in about $90 million a year. The fund also receives revenue from premiums paid by MinnesotaCare enrollees, which is about $33 million a year, $66 million a biennium. Premiums cover about 7% of the cost of MinnesotaCare. So those are deposited into the Healthcare Access Fund, but are used kind of directly to pay for the cost of MinnesotaCare. We also reflect a transfer in from the general fund in each biennium. In 1819, we reflect a $50 million transfer from the general fund to the Healthcare Access Fund, and that is the result of statute that directed the Department of Health to study state spending on chronic disease, and depending on the results of the study, which was released last December, they found that actual spending on chronic disease was less than they had projected, and that through a series of sort of analysis triggered this $50 million from the general fund to the Healthcare Access Fund. And then we have a variety of other revenues like interest earned and federal reimbursement for some eligible administrative costs that make up the remainder of our revenue. Before I move on to spending, are there any questions? Oh. So this chart looks at the current uses in the Healthcare Access Fund in the current biennium and the next. So MinnesotaCare was historically the largest expenditure in the fund, but that has changed due to both increases in federal funding and significantly lower program costs. The Healthcare Access Fund now spends about $110 million a biennium on MinnesotaCare, and that is both the state appropriation, but also those enrollee premiums I discussed on the previous slide. So it's about the $65 million from enrollee premiums, and then more like $45 million from the state share. Then the largest expenditure under the current forecast is for medical assistance. The Healthcare Access Fund spends about $800 million per biennium on medical assistance, and this amount is set in law in the Appropriations article, and it offsets how much the general fund spends for that program. Right now, the Access Fund covers about 6% of the total cost, the total state cost of medical assistance. So there are also a number of appropriations to state agencies in the Healthcare Access Fund, including to DHS for the cost of running MinnesotaCare, to the Department of Health and the Department of Revenue. So the purple bar on the chart is a transfer it's a statutory transfer from the Healthcare Access Fund to the general fund. Right now we forecast that will transfer $122 million a year from the Healthcare Access Fund to the general fund, and that is contingent on there being enough money in the fund to make the transfer. So if we were to experience a deficit, that would reduce or go away, depending on how the size of the deficit. And that originated as a way to sort of a way to make the general fund whole after we expanded the provider and premium tax to state public programs. And that's we can talk about that more in detail if you're interested. The last expenditure I wanted to highlight is $401 million of a transfer to the premium security account. This is the account from which we pay our reinsurance program, and that is transferred out in fiscal years 2018 and 2019. So now I just want to review a couple small changes we saw in the February forecast. Last November, we forecast a balance of $612 million in 2018-19 and $87 million in fiscal year '21. The balance in each of those years is slightly lower following the February forecast, and that is because of two changes. One, we're forecasting slightly lower collections of the provider tax, which is just the result of some updated data from the end of calendar year 2017. And then, as Mr. Welch discussed earlier, we have slightly higher state costs for MinnesotaCare, just $1 million in the current biennium and $5 million in the next. So that brings us to our February forecast balance of $604 million in 2019 and $61 million in 2021. Finally, I wanted to sort of walk through an outlook of the fund. We have on this chart, the blue bar represents revenues into the fund, sort of money coming in, and the green represents the transfers and expenditures, the money going out. You'll see from fiscal year 2018 to fiscal 21 that spending exceeds revenues in the fund. This means we have a structural deficit. And the reason that the fund's able to support this is because there was this large balance sort of going into this period. But in fiscal year 2021, that's the first year where we have no revenue from the provider tax. And in that year, the structural deficit is forecast to be $526 million. That is the end of my sort of prepared presentation. I'm happy to take any questions.
Representative Schultz.
Thank you, Mr. Chair. Do you know how much money we've spent from the reinsurance program out of the premium security account?
Ms. Mingy.
Mr. Chair, Representative, I believe right now we have only spent money on the sort of some of the administrative costs. The Department of Commerce is here if we're interested in talking more about that. We also have published a premium security account statement with the forecast, which we can provide to members as well.
Oh, yeah. Representative Schultz, Mr. Brickweedy's going to be up in a little bit, so we can probably direct those questions to him. Other questions? Ms. Mingy, I was wondering if you could just talk, you talked a little bit about the MinnesotaCare and, you know, the Healthcare Access Fund was set up to fund MinnesotaCare, as you pointed out, and that has changed over time with the expansion of Medicaid, and we've got kind of a different program. Can you talk a little bit about, just in terms of MinnesotaCare, just how that gets paid for currently, and how, about the 100,000 people, just how much of a percentage comes from the federal government, what's the state, and how much of that as a percentage is the premiums that folks write out in their checkbooks?
Mr. Chair, in the current biennium, the forecast reflects that about 7% of costs are paid for by enrollee premiums, about 88% is covered by the federal government basic health program payments, and then about 4.5% is funded by state appropriations from the Healthcare Access Fund.
Okay, and how much was premiums?
Mr. Chair, 7%.
7? Okay, thank you. All right, and Mr. Greenman's going to be back up and talk about, I guess, the program expenditures if we have other questions about that. But I think the structural imbalance of this fund with the depleting revenue sources, I think, should make sure everybody pays close attention to that, particularly if folks want to spend money out of the Healthcare Access Fund this year, that is not getting filled up with any, it's a bucket with no spigot. As we closed out last session and the session before that and the one before that, kind of want to remind ourselves of that, but here we go again. So Representative Liebling.
Well, thank you, Mr. Chair, and just kind of to that, another kind of question along that line. We have, it's kind of hard to read the slides on the printout here because they're not in color, so I'm not entirely sure I've got this right, but on the Healthcare Access Fund expenditures bar chart here, it's where it's showing that quite a bit of money is going to medical assistance. And that is, just if you would refresh my memory, I think that was what happened in this last budget, was kind of backfilling cuts to medical assistance and taking money out of the Healthcare Access Fund, because that's not something we've really done until sort of recent years. We didn't pay for medical assistance out of the Healthcare Access Fund, right? And so my real question, I mean, you can tell me if I've got any of that basic information incorrect, but going forward, since this is now a bucket with no spigot, what's going to happen with that money that is now funding medical assistance that is no longer going to be in the bucket?
Ms. Minky?
Mr. Chair, Representative, so the first appropriations for medical assistance from the Healthcare Access Fund were made in the 2013 legislative session for 2014 and 15. The size of those appropriations has grown over recent legislative sessions. The answer about what happens going forward is, it's a good question. We will, for the first time, publish a forecast for the 22-23 biennium in the coming November 2018 forecast. And at that point, I think we will sort of work with decision makers to answer the question.
So, Mr. Chair,
Representative Leland.
thank you. If I could then. So, in other words, there's going to be a hole that somebody's going to have to decide how to fill it, or because clearly we didn't do and I agree, we've started small, kind of going to the Healthcare Access Fund to fund Medicaid, medical assistance, which was kind of a new thing, and people used to protest loudly when there were attempts to do that. And then we started to do it, and then in this most recent biennium, there's a big chunk coming out of that. And now with that source of funding going away, there's got to be some real decisions made about what's going to happen, because this is an ongoing program without sufficient ongoing funding.
Correct. Thank you, Ms. Mingy.
Thank you.
All right, Mr. Brickwitty, are you ready? Welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Mr. Chairman, for the record, Peter Brickwitty, Assistant Commissioner at the Commerce Department. My apologies in advance. I'm regaining my voice over having lost it over the weekend. So, Mr. Chairman, I think members should have a copy of a letter from Commissioner Lumen that she sent to the reinsurance bill conferees from last year earlier this week. And that letter provides the most recent update on the state's 1332 waiver and the Minnesota Premium Security Plan, or MPSP. Our most recent kind of official action on the waiver is that federal agencies in late January updated the estimated amount that the state is expected to receive in federal pass-through funding for calendar year 2018. That amount is estimated to be approximately $130.7 million. That amount is $8.5 million approximately less than the amount that the federal government estimated in its previous estimate, which was in October of 2017, but that is more than the state was estimating that it would receive in its initial 1332 application. According to the terms and conditions of the state's 1332 waiver, which the state and the federal government executed in October, final payment of the federal dollars for calendar year 2018 is expected by the end of April. Commerce staff is in regular contact with the federal regulatory staff. We were recently handed off from the application staff at CMS to the implementation staff at CMS. Under the terms and conditions of the waiver agreement, the state has several reporting requirements due to the federal government, the most recent of which was yesterday, which Commerce completed and filed on time with them. That was a brief summary where the federal government was asking for a high-level narrative summary of the operations of the program and a summary of the plan for processing reinsurance claims. Commerce and MMB staff are also in close communication with MCHA staff and the members of the board. The MCHA board, who serves as the administrative agent of the reinsurance program, as members will recall, is next scheduled to meet on March 12th. MCHA has issued RFPs for actuarial, accounting, auditing, and claims processing vendors, and my understanding is the board is planning to review those RFP responses at their next board meeting on March 12th. The MCHA board at its previous meeting voted to establish a single payment to eligible health insurers by August of 2019 for reinsurance eligible claims incurred in 2018. And so I may repeat this for Representative Schultz, but in answering her question, the expenditures to date from the state have just represented a small amount granted to MCHA for administrative purposes, but there have been no payments made to carriers as part of the program, and there are not expected to be any payments until August of 2019 for calendar year 2018 claims. Commerce is serving as the fiscal agent for state appropriations appropriated to the program. And the letter also, lastly, Mr. Chairman, mentions that MCHA submitted the 2019 proposed payment parameters for the program, which they were required to do by law, to Commerce for review and approval. Commerce approved those 2019 payment parameters in late December of last year. They are the same payment parameters as were established by the legislature for 2018, which serve to maximize the total potential size of the operations of the program. And with that, Mr. Chairman, I'm happy to take questions.
Thank you, Mr. Brickwitty. Questions for the testifier? Representative Liebling.
Thank you, Mr. Chair. Mr. Brickwitty, do we have sort of final numbers on the impact of the insurance company subsidies on premiums?
Mr. Brickwitty.
Mr. Chairman, Representative Liebling, I think the best representation of what the impact of the reinsurance program was viewable in the two sets of rates which the legislature required insurers to file with the department this past rate review season. And you could see in what was filed by the carriers that there was approximately a 20% decrease from where rates otherwise would have been, which is in line with what the state was projecting during the legislative process on the proposal last year.
Representative Liebling.
And Mr. Chair, thank you. And Mr. Brickwitty, do we know what the increase would have been? I mean, is there kind of a, what was the inflation, the inflation that would have been in insurance premiums?
Mr. Chair, Representative Liebling, I want to be very clear. The reinsurance program did not necessarily result in a rate reduction, but the reinsurance program was designed, and I think accomplished this task, to reduce rates by approximately 20% from where they otherwise would have been coming in to the market for 2018. So I don't have, off the top of my head, the percent difference of the average rate increase for this past year, but I can retrieve it from the office and follow up with you.
Representative Loeffler.
Thank you, Mr. Chair and Mr. Brickwitty. The reinsurance covers claims between $50,000 and $250,000. And do you have data on what percent of hospitalization claims were impacted by that in the market? We helped with 10% of the claims, 5% of the claims, handled by insurance companies. And how accurate were we in estimating, that range in terms of being the point at which we could get maximum value for the dollars invested?
Mr. Brickwitty.
Mr. Chairman, Representative, we won't know the answer to that question in full until after the end of 2018. The reinsurance claims will not be paid for calendar year 2018 until August of 2019. So the plans are responsible for transferring data related to reinsurance eligible claims to MCHA for validation for eligibility for the program. I will say, kind of in response to your first question, the reinsurance model that the state enacted with an attachment point of $50,000 covering claims at 80% up to $250,000 cap covers both acute and chronic conditions. So any claim, regardless of what type of situation would bring a person in for care that exceeds $50,000 in that range would be eligible for the program. So I don't know if we will, A, have data on it now, and B, would not have data until the end of the 2018 claim cycle.
Thank you, Mr. Chair. And to the degree that you can help analyze that in between, and it sounded like maybe MCHA wasn't actually going to get the data until the end of the year, but it seems like most systems, we get regular reporting, and it would be really useful to know ahead of that, the closeout of the 2018 year, what's actually going on. That would be helpful.
And Mr. Chairman, Representative, I do believe MCHA has some quarterly reporting requirements under the statute that was enacted in the past legislative session with regard to providing information back to the plan. So that may provide some of what you're looking for as we move forward. But that process has not fully started yet because MCHA has not put in place contract with their vendor at this point.
All right, thank you.
Mr. Brickwitty, I just had a question about the 134 from your letter and from the little worksheet that you had associated with it, just how that's being tracked in the forecast, and then how much of a change was that from the previous, from before the forecast? Is that measurably different?
Mr. Chairman, just to clarify, you're asking about the $130.7 million estimated amount?
Yep, the one from your letter.
Mr. Chairman, I would defer to colleagues from MMB on the forecast change from November to February, but I believe, and they can correct me if I'm wrong here, but I believe that MMB was tracking the higher amount, the almost $139 million that the state was told by the federal government that they were estimating the state would receive for 2018 in October of 2017 when the terms and conditions were first enacted, and then we received subsequent update in January from a letter from CMS. After we had engaged in our first reporting requirement, we had to send some actual enrollment data for the end of 2017 to the federal government. They reran their calculations and came back with this $130.7 million amount.
So our number, the more conservative number, was I'm assuming that would have been the number that was projected in the forecast.
I think it was, Mr. Chair, I may defer to MMB because MMB puts together the forecast, so I don't know precisely.
Ms.
the
Mingy
answer
can
to
get
the
back
question.
to me on it. That's fine. That's fine. All right, other questions? All right. Is Mr. Greenman ready?
Thank you, Mr. Chairman.
Thank you, Mr. Brickwitty. Committee recognizes Dave Greenman. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair. My name is Dave Freeman. I'm the Budget Director at the Department of Human Services. I was asked today to come in and talk a little bit about, provide some background on the CHIP program and the Basic Health Plan. Just to kind of orient you, I think you've got in your packets a one-page overview of the CHIP program you should have available to you. And then you should also have a sort of a spreadsheet document that's in your packets that shows the funding for the, or the balance for the Basic Health Plan based on the February forecast. And I think a lot of the information I was going to share, I think Mr. Welch kind of covered already as part of his forecast discussion, but real briefly about the CHIP program, just so people are, in case people aren't familiar with it, we use our CHIP dollars to basically supplement existing Medicaid funds to provide health coverage for low-income Minnesotans. And we cover essentially three populations with our CHIP dollars. We use our CHIP dollars to cover three populations: infants under age 2, and that's a small group of infants, about 200, that are between 275 and 283 of the federal poverty guidelines. We cover non-citizen pregnant women who don't qualify for Medicaid with incomes up to 278% of the federal poverty guidelines. And then we cover children on Medicaid with incomes between 133 and 275 of poverty. As you know, and the way we spend our CHIP dollars is we claim the federal CHIP match on on spending for covered populations. So for example, for the Medicaid program in Minnesota, we generally get a 50% federal match on our spending. For the CHIP program, our base matching rate is 65%. And so, however, under the Affordable Care Act, it temporarily increased the CHIP matching rate, the federal matching rate for CHIP by 23 percentage points, so that between 2016 and 2019, we'll be drawing down federal matching funds, or federal funds against our CHIP allotment at a rate of about 88%. So that's our matching rate for the CHIP program, and that's until September of 2019. As Mr. Welch mentioned, and as you know, the CHIP program was discontinued by Congress on September 30th of 2017, and during the interim period before it was restored, Minnesota was using CHIP dollars from previous years, that had remaining CHIP dollars from previous years, and also temporary federal funds to keep the program operating. The funding at the time, and I think Mr. Welch mentioned too, that we projected a general fund loss of $178 million as a result of the loss of CHIP funding. And that was based on an assumed annual allotment of $95 million a year that we were losing as a result of the CHIP dollars. In January of 2018, Congress restored CHIP. Our CHIP allotment for 6 years, or CHIP funding was restored for 6 years, and then it was extended for an additional 4. Our CHIP allotment annual allotment is $122 million a year, and that's for this year and next year. And so the net general fund impact of restoring CHIP is $225 million for fiscal years 18 and 19. Under the continuing resolution that it reestablished CHIP, the CHIP matching rate was decreased to 76.5% for federal fiscal year 2020, and then goes back down to the base rate of 65% in federal fiscal year 2021. All right. Next is the basic health plan. Minnesota is one of 2 states with the basic health plan, Minnesota and New York. In Minnesota, our basic health plan is MinnesotaCare. The program provides coverage for about 82,000, average monthly enrollment of about 82,000 Minnesotans with incomes that are too low to qualify for Medicaid, or too much to qualify for Medicaid, but earn less than 200% of the federal poverty guidelines. Before the Affordable Care Act, MinnesotaCare was a Medicaid waiver program for which the federal government provided about 50% of the federal funds. Under the basic health plan, MinnesotaCare is financed through 95% of the premium tax credits and subsidies that enrollees would have received had they purchased health coverage through the individual market and the exchange, through the exchange. With the Healthcare Access Fund picking up whatever remaining funding there is needed for the program. Today, MinnesotaCare is funded almost entirely with federal funds and with enrollee premiums. There were two issues that came up in the last 6 months affecting, or maybe a year, I guess, maybe affecting funding for the BHP. The first was the 1332 waiver. As you know, in 2017, the legislature passed a bill that created the reinsurance program to address the high cost of insurance premiums in the individual markets. In May of 2017, the Department of Commerce submitted a 1332 waiver to the Centers for Medicare and Medicaid Services, basically to start the process of establishing the reinsurance program. Basically, what the waiver, because of our basic health plan is dependent on, the federal financing is based on premium tax credits. As premiums go down as a result of reinsurance, our federal funding would go down, and as a result, we would get less funding for the basic health plan because of reinsurance. Well, the waiver essentially asked that the federal government disregard the reduction in premiums due to reinsurance when they provided our financing for the basic health plan. The federal government declined to do that. They approved the waiver, but they declined to hold MinnesotaCare harmless. And so as a result, we lost federal funding, and based on the February forecast, under MinnesotaCare, under the 1332 waiver, we lose approximately $236 million in federal funds between fiscal year 2018 and 2020, and that's basically for calendar years 2018 and 2019. The second issue that came up regarding our basic health plan funding has to do with cost-sharing reduction payments, or CSRs. CSRs are, since the passage of the Affordable Care Act, the federal government has been providing cost-sharing reduction payments to health insurers as a way of reducing the cost of providing affordable health coverage for lower-income consumers. MinnesotaCare qualified for these CSR payments as a funding source for the BHP, and those payments accounted for approximately 25% of the funding for the basic health plan in Minnesota. On October 12th of 2017, the White House announced that it was discontinuing the CSR payments, and those payments were discontinued effective January 1 of 18. Based on the February forecast, we project that discontinuing the CSR payments will have a cost of approximately $445 million, or a loss of federal funding amounting to $445 million to the basic health plan, and that covers fiscal years 2018 to 2021. So the total loss, combined cuts to MinnesotaCare from the 1332 waiver and from the loss of the CSR payments, means a loss of funding of about $681 million to the basic health plan, covering the years fiscal year 18 to fiscal year 21.
And Mr. Greenman, could you just kind of going back to our earlier discussion before you came down, we were talking about just the structural balance for the Healthcare Access Fund and specifically to fund MinnesotaCare. If you look at what goes into paying for MinnesotaCare right now, the different revenue sources that we use to spend on that, and compare that to 2021, what percentage of the revenue sources are going to be left after we take away the provider tax, CSR, and the other revenue stream that I'm not blanking on, that we're missing out on? What percentage of how we pay for MinnesotaCare is going away as revenue sources for 21?
Mr. Chair, well, we'll continue to get premiums from our MinnesotaCare enrollees.
Okay, that's 7%.
Yep. We'll also continue to get tax credits through the basic health plan to pay for MinnesotaCare. I don't have the forecast in front of me, but I believe MinnesotaCare would be fully funded based on the February forecast in fiscal year 21, using the basic health plan, or using the federal funding through the basic health plan and enrollee premiums. I'm not sure if that's answering your question or not.
I think that if you look at, do we have enough money in the overflow or in the account plus the revenue streams, you could say, well, we can pay for it through then, but just from a budgeting standpoint, from a structural standpoint, what percentage of that is coming through with that year's revenue for, as we project forward? I think that's an important thing to keep in mind.
Okay. Mr. Chair, I'm not sure if I can answer that question right now.
Representative Gruenhagen.
Oh, thank you, Mr. Chair. Thanks for your presentation. And my question was kind of along the same lines with the loss of $681 million. How long would the BHP stay viable from a funding standpoint? Do you know that at all at this point?
Mr. Greenman.
Mr. Chair, Representative Gruenhagen, if you look at the handout we provided, this document right here, what it's showing you is it compares funding for the basic health plan to actual costs that are coming out through the trust fund. And if you look there's a line about halfway down that's called adjusted federal BHP revenue. And it's showing, for example, in fiscal year 18, it's showing $443 million. And if you look a little further down, you see the federal share from the trust fund. You see the costs, the expenditures going out of about $396 million. So that's where you're seeing that. You see there's actually a structural surplus that year in fiscal year 18. But as you move on into fiscal years 19 and 20, there's actually a deficit, and that's partly because of the reinsurance program that's temporarily in place. We're assuming in the forecast that the reinsurance program lasts for 2 years. If it were to last for a third year, we would have to go to the Healthcare Access Fund to pay for a portion of the MinnesotaCare program in fiscal year 21.
Okay.
And Mr. Greenman, I would assume that this would have differences. Let's say if we were to triple the amount of people in MinnesotaCare, let's say we went to 300,000 or 400,000 people, that would change the projections.
Mr. Chair, yes, that's correct. We would have additional tax credit revenue coming in. Certainly, we would have additional costs as well to cover that population.
All right. Other questions for Mr. Greenman? All right, seeing none. Thank you, Mr. Greenman. All right, next we have update on the insurance premium rebate program with MMB, Mr. Hallstrom. Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chairman, members of the committee. My name is Eric Hallstrom, Deputy Commissioner at Minnesota Management and Budget. And I appreciate the opportunity to be with you today to talk about the Premium Subsidy Program. I think this is our first time to share with you kind of the results so far. In the fall of 2016, we began working with insurance companies to develop a system providing Minnesotans with relief from rising healthcare premiums. Particularly in the, specifically in the individual market. This was a priority for the governor, and it was one of the first pieces of legislation passed by the legislature last session. The Premium Subsidy Program made $312 million available to provide relief to Minnesotans and to stabilize the individual market in calendar year 2017. And I'm pleased to report the program has been successful. Through the Premium Subsidy Program, Minnesota residents who purchased health insurance plan on the individual market and were not participating in other public health care programs such as MinnesotaCare, who did not receive federal subsidies, received a 25% reduction in their monthly premium during calendar year 2017. And the program is administered by Minnesota Management and Budget, and we have provided relief to about 118,000 Minnesotans. I just want to talk very quickly about the program's design and implementation for the benefit of the committee members. One of the features of the program is that by providing health insurance companies provide the subsidy directly to individual subscribers, we were able to deliver relief to Minnesotans in the most efficient and timely manner. So in order to ensure only eligible Minnesotans receive the relief, we worked collaboratively with the Office of the Legislative Auditor, the Departments of Human Services and Commerce, MNsure, Department of Health, as well as health insurance companies. And we designed and planned and implemented a program. And during that process, we sought review at every stage, from the development of the program policies to the procedures for repayment or invoicing and payment, and made adjustments to those after review and consultation with our colleagues in the Office of the Legislative Auditor's Office, and ultimately established a program of processes and internal controls that safeguarded the state funds and delivered the relief fairly smoothly, all while standing that up in a fairly quick and timely fashion. I just would like to take a moment to say we couldn't have stood this up as quickly as we did without a couple of important individuals, and I think I'd just like to give them some credit. First, shortly after the law was passed, MMB's Deputy Director of our State Employee Insurance Program, Galen Benshoof, who's now actually the Acting Director of the State Employee Insurance Program, stepped in, did the Interim Director work for the Premium Relief Program, and we are greatly appreciative of his work in helping us kind of set up the framework until we were able to bring on our current director, Dara Johnson-Aodeli, who came on in early May. And she's been a tremendous asset to MMB in the program, and I would be remiss if I didn't mention she was also a Star of the North Fellow in the state of Minnesota, and just emphasizes how important some of those development programs are. She's with me here today if we have specific kind of in-the-weeds questions. Just briefly how the program works. Health carriers complete an invoice form requesting reimbursement each month, along with a set of supporting data. The invoice includes certification that the subsidy has been provided to subscribers that meet the eligibility criteria. We then review the submitted data to verify that eligibility criteria have been met and identify errors or corrections that are necessary. We then work with the Department of Human Services to ensure that subscribers are not participating in public programs like MinnesotaCare medical assistance. We then work with the health carriers to when corrections are necessary. And for example, one that we see a lot is that you'll have a subscriber who doesn't actually pay their premium for, say, April until June. And so we have a process for correcting prior months that allow us to get the proper subsidy out. The invoicing of this process is nearly complete, so let's talk about the money, which I think we're all interested in. As I mentioned earlier, there's original appropriation of $312 million for the program. During the special session in May, the Health and Human Services Omnibus Appropriation Bill required that $99 million of that original appropriation cancel to the general fund for certain specified purposes, as long as the program had adequate excess funds. That determination was made at the time of the November forecast. Commissioner Franz certified the appropriation for the subsidies program exceeded the anticipated obligations at that time, and that $99 million has canceled out of the original appropriation. As of last week, we received invoices for reimbursements from all the participating health insurance companies through the end of the calendar year. Expenditures for the program to date are roughly $137 million. Health carriers are reviewing their final reimbursements. They will send invoices for a kind of corrections period. We expect those to come in by mid-March. And this could include some additional adjustments both up and down, especially since we've got the bulk of those invoices in. This is the time for kind of modifying and correcting those previous invoices. The Office of Legislative Auditor has begun their process of auditing health carriers supporting data and are working directly with health carriers to understand the carriers' internal processes. And the OLA's role in this program is somewhat different than maybe a typical OLA audit. Their efforts are actually built into the program as designed, and they're able to make certain determinations at the end of the program that MMB was not able to make during during the calendar year, and will allow us to make some final corrections and clawbacks if there are in case any public funds expended that should not have been during that time. This is kind of the deal struck to get it moving quickly. While the individual subsidies have ended, there's still quite a bit of work to do to complete and orderly wind down the program. And at the close of the fiscal year, MMB will transfer the budget reserve to the budget reserve any unexpended amounts from the appropriation that haven't already been transferred, and it would be our intention to get the legislature a report kind of with the final accountings after all of that work has been done. And then finally, if I may, I'd just like to briefly mention the transition of care reimbursement provisions of Chapter 2 legislation that established the same bill that had the premium subsidy program required health insurance companies to provide care on an in-network basis for certain individuals who lost coverage due to their insurance company leaving the individual market. And the law appropriated $15 million for this purpose. Because that amount is capped, it's possible the health insurance company claims could exceed the appropriated amount. And so we will be doing a single claim process where we can then, if the number of the claims exceed the amount that was appropriated, we will prorate that equally across all claims as the law specified. So if there are any excess programs or funds from the transition of care account, they will also be transferred to the budget reserve at the end of the fiscal year, just as the subsidy program funds will be. And thank you very much. It's the end of my prepared remarks. Happy to answer any questions.
Representative Grunhagen.
Oh, thank you, Mr. Chair. Thanks for your presentation, and I've been a slight critic of MinSure and its operation. I will admit that. But I will say this program, although I don't like the idea of subsidies necessarily, but with the premiums where they're at, I voted for it, I saw the necessity of it. It did seem to go pretty smoothly between the carriers, and I own an insurance agency, sold health insurance since 1978, and so for the most part, it was satisfied customers. So if you deserve the credit, otherwise pass it along to whoever. So I can compliment people too, okay? But I got a couple questions, Mr. Chair.
All right.
Okay. First off, was there any federal money that came in to help with the 25% subsidy at all?
No, Mr. Chairman, Representative Gruenhagen, no. One of the eligibility criteria is that you are not receiving advanced premium tax credit subsidies. So this is really, it was designed as a gap filler for those folks who don't qualify for other assistance.
Okay, then just a follow-up question, Mr. Chair.
Representative Gruenhagen.
On that 15 million, did that go to people in particular for out-of-network, or did it, did the carriers, where'd that money go?
Mr. Chairman, so for the transition of care coverage, it is designed to, I think, to the extent that that $15 million makes possible, hold health insurance companies harmless if they are picking up somebody who lost their coverage or whose prior insurance company left the individual market. You have to have had you must have either a chronic condition, ongoing care for something like a pregnancy, possibly even a terminal illness. And it gives, I think, 120 days of continued coverage. And there's a calculation in the legislation that compares what your in-network and out-of-network costs would have been to insure that person. And if there's an impact to the health insurance companies, this fills in that gap.
Mr. Chair, one last question. But we don't have the final figures on that yet. Okay.
We do not. In fact, we've been part of the reasons why the premium subsidy program has been successful because of the close work we've had with the health insurance companies who have asked us, we'd like to get that one done before we do the accounting for the next one. And since we have a single moment in time where we're going to do that transaction that will cover the entire year, we can do that probably in April.
Yeah, just a suggestion. Maybe the group that handled this so well should move over to MinLars and do that one. Okay, just a thought.
Representative Lulin.
Thank you, Mr. Chairman. I wrote down the numbers that you gave us, and what I'm looking for is the administrative cost, MMB administrative. Do you know what that figure is?
Commissioner Hallstrom.
Thank you, Mr. Chair. The legislation, and it was a little, the location of MMB's appropriation for administrative costs is actually in the $15 million appropriation for the transition of care, so it just shows up in a different place in the bill. We received $272,000 as part of that appropriation for administrative costs, and I think $157,000 for the Office of Legislative Auditor for their piece of that. So combined, that would be the sum of the administrative costs associated with the programs. I don't believe we've expended $272,000, but I don't have my budget number with me right now.
Thank you.
Thank you. Representative Liebling.
Thank you, Mr. Chair. So thank you for that report. It's good to hear. I mean, I actually got a lot of contacts from satisfied constituents who were very grateful for that help. And just as an aside, I call it a discount program. I just think it's a little, at least that's sort of from the consumer side. It's just a discount. But anyway, I'm really interested in the report. So if I understood you correctly, we spent actually $137 million to give consumers in that situation a 25% discount off of their premiums that they otherwise would have paid. And now we have this so-called reinsurance program. I call it an insurance company subsidy. And it's a sort of a backdoor way of trying to do the same thing. But I'm trying to compare the costs now and the results. And if I'm right, and maybe you can't give me the numbers correctly if this isn't something you came prepared, but I think it was it $542 million was the appropriation over 2 years for the insurance company subsidy program. And then we also lost federal funds in that deal, although they came out of a different bucket. They came out of the bucket with no spigot. But nevertheless, I think that was, if I'm right, it was something like 277 million there. So just quick back of the envelope here, we spent like over 800 million on this new program, which is estimated to give people a 20% discount, not 25. So where am I, what am I missing here? Or are my numbers at least somewhat correct? It seems like per dollar saved consumer, we went from something that worked pretty well and, you know, gave them something they knew what they were getting and were pretty happy with, to now I'm getting complaints. People are saying, what happened to my discount? And my insurance rates have gone up. So can you kind of give us, am I lining up right on the numbers there?
Mr. Hallstrom.
Mr. Chairman, I would like to agree with Representative Liebling that I'm not probably well equipped to answer the question that she asked.
I gave you good help there.
I mean, I can really only speak to the premium subsidy program in terms of how it delivered that benefit. And as I had mentioned earlier, it covers a subset of the population that receives, and there are other programs in play providing support for folks who have a challenge acquiring health insurance, whether it's programs like medical assistance or the federal tax credits. So I just don't want to leave the impression that we provided we didn't provide a 25% reduction to everybody's insurance premium in the individual market. It's just that subset that don't qualify for other benefits.
Yeah.
Representative Liebling.
Mr. Chair, thank you. No, I think we all understand that. We're not talking about everybody, just people who are paying full freight,
Right.
who aren't getting any help. But that leads me to another question. Were there people in that group who didn't get the help, or did everybody, are we pretty sure that everybody who was in that category, who were not getting other help, they were buying their own, paying their own way, that all of those people got the discount?
Commissioner.
Mr. Chair and Representative Liebling, what we saw was a fairly smoothly operating program. We saw we had a lot of collaboration with legislative offices who did a good job of fielding those inquiries from their members. And I would say we had a good relationship with the companies. We left the relationship between the individual subscribers and their health insurance carriers between them. We did not mediate that relationship in any way, but I feel like we had a good track record for getting those folks who called us and said, I thought I was supposed to get a subsidy or supposed to get a discount, making sure that they got connected to it. And a lot of those came in through contacts with legislative offices. So I guess it's hard to know if we actually got to everybody. I feel pretty confident that based on the information flow that we've seen, that we were successful to the extent that you can be.
Mm-hmm. And Mr. Chair, if I could just...
Representative Liebling.
Thank you, Mr. Chair. So since you can't really answer my question, I'm not exactly sure who would give me the information, but it would be really instructive to have these two things kind of side by side to see how much we're spending, you know, including the fact that we lost a lot of federal money with this waiver. You know, how much are we spending for how much premium relief consumers are really getting in the state? Because it sure sounds like the first program was a real good deal, and the second one, not so much.
Mr. Chair, we certainly can work with our colleagues at Commerce and at the Budget Division of MMB and try to get some of these numbers for you to get a better picture.
Thank you.
All right, thank you for your presentation today.
Thank you, Mr. Chair.
Last up for today, we have the Department of Health. Commissioner Pollack, welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair. Dan Pollack, Deputy Commissioner for MDH. Happy Purim to everybody celebrating that. It's an ecumenical holiday because if the Jews had gotten wiped out, we wouldn't have had Christianity or Islam, so we can all celebrate Purim.
All right.
So, Chair Dean, Representative Murphy, thank you for the opportunity to present details of our recent assessment of the current science and data on the very real threats posed by toxic PFCs in our drinking water. First, I want to congratulate the parties on reaching a settlement agreement in the 3M litigation, which will serve the interests of the East Metro communities, hopefully for years to come. As MDH has reported for more than a decade, perfluorochemicals, or PFCs, do present a serious risk to human health, and that is why we established health protective values. We've been working with the MPCA to reduce human exposure in drinking water. Now, this settlement will help protect thousands of residents and communities with water and natural resources impacted by PFCs. MDH plans to work closely with DNR and MPCA to ensure that the settlement results in safe and sustainable solutions to drinking water problems in the East Metro. Over the past several years, MDH has made public its conclusions about the proven effects of PFCs. 3M's contamination caused serious environmental damage, and it affected the groundwater used by some East Metro communities as a source of drinking water. In some studies, higher levels of PFCs in a person's body were associated with higher cholesterol, changes to liver function, reduced immune response, thyroid disease, and kidney and testicular cancer. Beginning in spring 2017 and throughout the summer and fall, MDH engaged in ongoing conversations with the Attorney General about how cancer and birth outcomes data would be used or analyzed during the litigation with 3M. We worked for months to better understand a third-party expert's analysis to determine whether it was an accurate representation of the current data and science. In November, the punitive damages motion included various human health claims, and it resulted in extensive media and legislator inquiries to MDH, which compelled us to undertake a rapid reassessment of our data to make sure we could accurately answer questions with the most current information. The fact that we had significant questions about the third party's experts' analysis and that we needed to do this full reassessment were explained to the Attorney General's staff beginning in September 2017. We concluded our reassessment as quickly as possible, and we stand by our decision to release that assessment, which we did in February. The Attorney General's recent comments disparaging MDH were inaccurate and disappointing. Holding back our information would have frankly been a disservice to the communities. All of the parties in the litigation would have suffered, and the comprehensive fact-finding process that is legally required in every trial would not have happened. Our responsibilities include protecting Minnesotans from negative health effects and giving them accurate information about those threats to their health. We take that duty very seriously, and we're confident that we achieved both goals in this case. We base our information on the best scientific information available without favor or prejudice. Our scientists, several of whom are here today with me, examined vital records data, individual birth data, and detailed records on cancer incidents from the Minnesota Cancer Reporting System. Variation did not suggest any unusual increase in low birth weight or premature births in Washington County. Our findings regarding cancer in the impacted area agreed with our previous reports from 2007 and 2015. In addition, MDH found no unusual occurrences of childhood cancer in Oakdale. The findings of MDH's data review were consistent with the department's May 2017 update to guidance values for PFCs in impacted East Metro communities. Our results show that communities impacted by PFC contamination did not appear to be suffering higher rates of adverse birth outcomes or cancers as compared to non-impacted areas. Our conclusions are limited by the fact that we don't always know how long any individual resident resided in the East Metro or what that person's specific exposure was to PFCs via drinking water, or if they were exposed through other ways, such as through products. We know that over the past several decades, there's been a large influx of people into the East Metro who might not have been exposed in the same way as people who were born there and grew up there. We've looked at this new resident population in our biomonitoring program, and we report that data as well. The unknowns that we're not able to fully evaluate at this moment in time do provide support for continued safety actions to lower the level of PFCs in drinking water to protect the health, particularly for most vulnerable community members, pregnant women, newborns. MDH has not collected public health data on other types of potential health effects of PFCs that are reported in scientific literature, such as liver and kidney effects, thyroid disease, and immune system changes. While MDH's water guidance values are designed to protect against all of these effects, data on their occurrence in people are not currently available. So going forward, we will continue to analyze and share the best information we have available so the Minnesotans can make well-informed decisions about their health. We're proud of the exceptional investigative efforts of our scientists work in this area, and I'm happy to have them here to answer any questions you may have on this subject. Thank you again.
Thank you, Mr. Pollack. Questions for Mr. Pollack? Representative Lieber.
Thank you, Mr. Chair, and Mr. Pollack, so, sorry if I missed this, but I assume that the study is not really over and it'll sort of continue? I mean, how long does the department, I know this kind of thing is extraordinarily difficult to study because of a lot of factors that you mentioned. But the really important thing is that sometimes you don't see outcomes for a long time. So is this something that the department's going to keep up with?
Commissioner Pollack.
Mr. Chair, Representative Liebling, yes, we will continue to do biomonitoring, to continue to do the cancer surveillance analysis, both in that community and statewide. The reason that the levels dropped back in May, which was well before the start of the trial, related to emerging science and new information that was being looked at. So we will continue to do that research.
Representative Fisher.
Thank you, Mr. Chair. I've got a couple of questions. I heard you say very clearly that you're focused more on cancers and low birth weights. One of the questions I have is, besides some of the, you mentioned some of the diseases that could be affected by this but were not studied. What are the thoughts in terms of studying that? Also, does it possibly lead to anything else in terms of fetal development that could lead to autism or those kind of things? Those are some of the questions I have. Another set of questions that I have in the area would be, I know that when the water was being treated initially in the East Metro there, some of it was sprayed up in the air, then it came down, ended up in the soils there. So was anything looked at crops in the area, how the uptake was on crops and how that would impact people through there? And then also finally, any that would be in the watershed is if they came up through the fish population, as mercury does, it becomes more concentrated. Was that impact looked at and studied and what those results would be?
Commissioner Pollack.
Okay, Mr. Chair, Representative Fisher, I'm gonna phone a friend and have some of come up, and then Jesse, you want to take on?
Please introduce yourself for the record, and you could answer Representative Fisher's questions about crops, fish, sprayed water, non-cancer.
Both adult and in fetal development.
Fetal development and adult.
Mr. Chairman, Representative, my name is Dr. Alan Bender. I'm the Section Manager of Chronic Disease and Environmental Epidemiology at the Department of Health. Just to clarify, we responded to the contention that there were excess abnormalities relative to adverse birth outcomes and cancer in the community. Currently, in the data that was available to both the Attorney General's analysis and to ours, we use more complete and more data standards of the public health community in terms of analyzing this, and we found no evidence of that. The issues that the representative is describing is something else. It's how would you determine if there are other health impacts in that community? What kind of study design would be required to do that? And the answer is that one that has been done in other communities out in West Virginia. And just to put a perspective on it, the type of epidemiologic design to start to address that question, not whether there are current issues, but whether there's long-term issues, referred to as the C8 studies with the DuPont issue, and required many years and tens of millions of dollars. So no, we didn't address that, and there's nothing that we've planned at this time to address it, because that would be a very different kind of effort.
Thank you. Representative Fisher.
Thank you, Mr. Chair. Nothing has been studied. It's expensive to do. So there's no way to rule out if there aren't other causes or other impacts that could eventually be felt by the communities that may end up not being addressed as they have their settlement out there. Is that possible?
Mr. Chair, Representative, that is addressed in another way. That has to do with the level, the health-based values, and what our colleagues in toxicology and the environmental health sciences know about the levels of risk in protecting the community from those possibilities. And I'm going to stop right now because I'm really getting into someone else's discipline, but it's addressed, but not through study. It's addressed through regulation.
Mr. Chair, if I could just add, and Representative Fisher, so We do have a biomonitoring program ongoing, and that has looked at people in the agriculture sector in the East Metro. It's voluntary. People can participate and be looked at in terms of what the health impacts are to them. I think your question about specific damages or causes that may have been included in the lawsuit or not, we weren't a party to the lawsuit. So we weren't included in those discussions. We weren't included in any discussions around the settlement. So all of those questions have to be addressed to PCA.
Representative Fisher.
Thank you, Mr. Chair. Just follow up. And I understand the PCA portion of it and understand that, but I'm also looking at the other issues that may come out, because I know that some people have been saying with where the detection levels are right now, there seems to be no health effects and that we're overreacting on it. And I'm trying to find out if there are other things that might be circling in there, because I don't want people saying, oh, there's nothing wrong. And it turns out there are these other things that have been studied that eventually crop up down the road.
Representative Franzen, happy birthday. All right. Didn't want to let you go without recognizing your birthdays. All right. You bet. All right. Dr. Bender.
Mr. Chairman, Representative, this gets into what my colleague to my right now is going to discuss with you, and that's a different, I think the confusion, and you're addressing a very important question that involves three different issues all kind of conflated with each other, and they all involve risk. What is the level of risk that the regulatory agencies strive to protect? What is the level of risk that epidemiologists can go into the community and study and identify? And what is the perceived risk of the community based upon exposure? And they all get meshed together with the type of question that you have, and we'll see what my colleague has to say.
Recognize Mr. Kelly. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair. My name is Jim Kelly, and I'm a manager in the Environmental Health Division at the Minnesota Department of Health. And I can speak a little bit to some of the representatives' questions that haven't been addressed in terms of the types of health risks that we considered when we developed our health-based values. They include things like cancer, liver effects, effects on the thyroid, and effects on a host of organ systems that have been demonstrated in animal studies. And the values that we developed for exposure to these chemicals through water are protective against all those health effects. So we don't, based on where the levels are set today, we don't expect to see those kinds of health effects in the future. But they're important that we protect against them nonetheless. And to get back to your earlier question about fish, the three departments, PCA, DNR, and MDH, have been monitoring fish populations in the East Metro and statewide, in fact, for levels of perfluorochemicals. And that work will continue, and fish consumption advisories have been issued for certain water bodies where levels of PFCs are above where we would like to see them in terms of frequent consumption of the fish. So that information is available on our website and through the DNR's Fish Finder website as well. And then lastly, your question about produce and farming practices. The department did a study of gardening habits in the East Metro communities that have been most impacted by this contamination. We collected literally hundreds of samples of a variety of produce and tested them for perfluorochemicals. And what we were doing was really looking at the worst case situation, in that these were home gardens that people had been gardening in some cases for decades, using the water from the contaminated aquifers to water their crops. And what we saw was that there's really very little uptake from these watering sources into the crops. And our conclusions were that the benefits of growing home produce and the benefits of eating fresh produce far outweighed any potential risk from the small amount of PFCs that we could detect in some of the produce that was found. And we just recently published that study in the scientific literature, so it's something that's being looked at quite a bit in other parts of the country as well that have been facing this issue.
Thank you very much. I appreciate the advice and input that you're providing. Helps me.
Thank you. Other questions? Representative Schultz.
Thank you, Mr. Chair. So I'm assuming you have a much fuller report that we can access online about your analysis. I'm wondering if you could answer just a few questions. How many people did you follow? It said you collected samples from 164 residents. And when you split that by length of time that they've been drinking the water and where their water source is, whether well water or city water, I'm wondering if you are losing or are able to look at statistical significant differences in the samples with that small of a number of individuals that you've tracked?
Ms. Schmuel.
Okay. Hi, I'm Dr. Jessie Schmuel, and I'm a supervisor in our environmental epidemiology unit at the Department of Health. So I think your question is referring to our biomonitoring studies that we did in 2008, 10, and 14, correct? So the statistical significance question, whether we were able to, whether those populations were large enough to detect, to have statistical significance, can you restate your question?
I'm just wondering if the sample size was large enough, once you break it down by the number of years they were drinking water, where the water source was from, which aquifer or well or the city water.
Right.
And then if you can find differences that are statistically significant
Yes.
in the blood samples or in your even larger study.
Dr. Schmuel.
Thank you, Mr. Chair, Representative. Yes, so in the biomonitoring study, we were able to calculate statistically significant associations and differences in those populations. And what we were doing was comparing differences over time. So in the biomonitoring studies, we were looking to see that the serum levels in the sampled population as a whole was of long-term residents were coming down over time in a manner that would be consistent with the known half-lives of the chemicals in the body. There was a subsample of shorter-term residents that moved into Oakdale after, who would not have been exposed to PFCs through the drinking water. And so there we were really looking at whether the levels in their serum, how that compared with the national levels that we look at through the NHANES. And so looking at individuals, you would not be able to have a statistical significance. But when we're looking at those groups across time and in comparison to national baselines, yes, we were. And we were found that those results demonstrated the efficacy of the interventions to reduce exposures and did not indicate that there were any other unidentified exposure sources in the area that were impacting folks.
Representative Schultz.
Thank you, Mr. Chair. So you did find concern based on the blood levels of those drinking water over time, a longer period of time. And then what did you do with those individuals? Then you tested for negative or adverse health outcomes or health conditions of that subpopulation?
Dr. Schmuel.
Thank you, Mr. Chair, Mr. Representative. I was not on staff at the time, and so I do not know exactly what our results return and our protocol was for following up. I know that we had follow-up with clinicians. In some cases, we had home visits. We do have that protocol that was approved through our IRB, and I can provide that to you at a later date. But they were, participants were reached out to in multiple different ways, and again, with my multiple different agencies when we found elevated cases to address water as well as health concerns.
Okay, one more question, Mr. Chair.
We are going to have to wrap up. We're 5 minutes over, and I know folks have to get to caucus ahead of session. So I'd like to thank the department for coming in and for updating us on the settlement, and I'm sure we will hear more about the expenditures as well as the health effects of the East Metro constituents that we have. Thanks to all the agencies for coming in. With that, we are adjourned, members.